What we're going to do today is talk about the monitoring of the side effects, and we're going to start broad and get into specifics, and specifically lead into the two main medications, groups, if you will. And the first one being the antipsychotic medication. That's to treat ADHD, So it's going to be antipsychotics and then the medications for ADHD. Why? Because antipsychotics, because of the more serious and more profound potential metabolic and other problems, and then the ADHD meds because they're being the most commonly prescribed when you look at volumes of numbers, et cetera, as we go through. I don't have any conflict of interest that would be pertinent here, by the way, right? So what would be the goal? Just remember, we're starting very broad, right, of monitoring for these side effects is obviously to look at things like outcomes, improve adherence, the quality of life, decrease the side effects, and then help facilitate appropriate cost-effective decision-making. Oh, everybody needs to get an MRI if it's the first of this. Everybody, you'll see, we're going to talk about EKG. Everybody needs to get an EKG, and what's appropriate, what are appropriate monitoring decisions, and not just fiscal, but what's evidence-based to guide that. And some of it's not always clear, right? What are some of the barriers? As you know, the literature is a little dirty because it's very hard to kind of really get a good handle on these things. It's better in certain areas and in closed populations or clinics, right? But that one is the prescriber's ability to be familiar with what they're ordering, and then what do you do when I get the results, right? Two is their perception that this monitoring takes up extra time, or that it takes time to follow up. I see you now, and then I'm going to order this, and then that comes into my queue and my EHR or whatever, my fax, if you will, and then I need to follow up on that, and then do I wait until the next appointment, or how do I follow up that it's extra time? Three is what has been discussed here already is about collaboration and coordination among the different specialties. And four, related to that is, well, that your pediatrician's taking care of that, or I'm going to order the labs because I couldn't get the labs from the other person, so we're going to almost duplicate it, if you will. Now, we know some EHRs help integrate if you're especially in a system, but by far, when you talk to practitioners across the state, they're in these other kinds of practices that don't always facilitate that, right? So these are some of the issues, and that's why you mentioned about getting releases and coordinating and obtaining information, because it's a matter of getting it done and how to do that in a timely, cost-effective way. What's the biggest barrier from the patient side? Well, it's access to the services, right? And we've talked about it. That's part of some of the social determinants of health that come out. The big one we talk about is childhood obesity, and we know that it's been increasingly prevalent over the last several years, and that it's not just going to go away, right? And that it's not just a childhood problem, right? So if that child is overweight or obese, there is now increasing evidence about how that transfers into adulthood, and that all the resulting consequences or complications of that, including all your metabolic syndrome, cardiovascular syndrome, and that whereby we used, I guess, many years ago, diabetes was much more an adult disorder, and how the prevalence of diabetes in childhood and adolescence has really increased, along with the use of medications that were somewhat more exclusively within the adult domain, now being used with kids as well. That's we said that if obese children are increasingly likely to remain obese as adults, and this is part of what we're trying to work, change, help. When you look at the health economics of this, the impact of all of these things over time, and you look at, it's not just in the US, when you look at the global impact of especially in the higher socioeconomic countries, that just in general having a mental illness is also a risk factor is associated, high correlation with also physical illnesses, and then all of these, how they tie into life expectancy, not just necessarily quality of life, but life expectancies. Some general, and I put select, some of the principles of practice for kids, and a lot of you know this already, but this is again just to emphasize, right, that there are some guidelines that go out and say antipsychotics should only be used in a very narrow way for schizophrenia or bipolar, the youth, period, but that you really should have a justifiable indication after a good, thorough initial evaluation. So that's a little bit more broad, right, as you justify that. And if anybody who does monitoring or reviews, you could see, gee, you could justify it vis-a-vis diagnosis, but you could justify it by looking at the actual justification by the practitioner on its use, right? That as a rule, we don't want to start 2 or more meds or 2 or more antipsychotic meds concurrently. As you know, when we've said this over and over again about using just antipsychotics as a first choice, first line, or even as the singular intervention for behavioral symptoms. These are global, right, and dementia as well, because this is from choosingwisely.org. Do not use them for insomnia. And we say this in the adult guidelines, use it for the kids guidelines. The red is inserted by us. That the potential metabolic issues and the fact that there isn't a clear endpoint for those use of those medications for insomnia, and the fact that the evidence doesn't support, if you look at quetiapine, et cetera, on their use, even though there's a lot of anecdotal information, people using it, that we do not recommend that. And then number 5 is the same as number 3 about not using it to treat solely the behavioral issues, or that there needs to be sufficient evidence support for the use of it, and some would argue that the threshold's even higher for kids and it really should be across the ages. You can see in a lot of the most of the guidelines, there's a section. It could be clustered chronologically by age, so it's below 6 to 12, 13 to 17, that is preschool, childhood, and adolescence. Some guiding principles for kids, right, in preschool age is that we know that younger children are more sensitive to medication side effects than older youth, that there's very limited good scientifically rigorous evidence on the use of our meds in kids that below the age of 6. And remember what we know, that just extrapolating from adult literature, extrapolating from childhood or adolescent literature is a lower level of evidence, and it may have some face value, but it may not be, as we know, appropriate. And we know that, for example, from the antidepressant literature in adults and what we know in adolescents, let's say. So same thing for children under the age of 6. It's big flag here, obviously, and in other places, is the use of antipsychotic medications in children 5 and below. That you really should have a higher threshold for justification, and you want to use it with a lot extreme caution. If you can find your clinical justification, great, but be really even more cautious. And then to take into account these very different developmental considerations for young kids, obviously, and that to look at all of these non-pharmacologic interventions, which is the theme anyway, but it's again, it's a higher valence, higher weight for preschool kids to kind of look at implementing those services before you consider meds, right? So then when we move from small kids to youth in general, a lot of these are the same principles as an adult, but with some modifications, right? And you can see a review of the other meds, right? That's part of your medication reconciliation, if you will, that we talked about. Again, some of these are pretty basic, right? But we're just reviewing that as a basis to what's going to be included in the document. That it's hopefully an interdisciplinary, multidisciplinary plan, that does not involve just medications, that it really would take some special justification to generate an initial treatment plan or an ongoing treatment, or maybe an ongoing, but a treatment plan that involves only medication use and no other interventions. So that's a general rule. Yes, not only does the evidence, but common practice suggests that it should involve that, and medications are one component of that intervention. And that, as we've said over and over again, that whenever you select a medication, you want to try to utilize the evidence base, the science, to guide your decisions. Now, hence, all of these guidelines and the tremendous efforts to provide guidance. Remember, it's guidance for the clinician, but based on the strength of the evidence. And let me just give one quick example here then. When you use stimulants, right? So if you look at stimulants as a class, if you look at them as a class, they're all fairly equally effective in treating the core symptoms, right, of ADHD. But when you really look at it, you go, gee, why does child A respond to this medication and child B respond better to this one and child C to this one? So what does that mean? That means equivalent efficacy doesn't translate into equal response in each patient, right? And so we know that, right? And so it's based on these other factors, but what we want to be very careful from saying is that when someone comes and says, oh, lisdexamfetamine Vyvanse, that's the medicine that works best in ADHD, and those kind of categorical statements aren't necessarily evidence-based. Now you can say, in my experience, maybe the majority of my patients respond to that, but when you look at these class effects, then you want to be very careful about, there may be truth in there may be some fact in what you're doing from a practical perspective, but when you present it so categorical, it's not quite evidence-based. So it's a little nuanced, but it's just to be careful as not only in how we make our decisions, but how we present it, right? Because every once in a while we'll hear that from parents, but I heard that it has to be mixed amphetamine, it has to be Adderall, that's the one that works best. And I go, gosh, better person than I determine that, but let's talk about that. And then the matrix of different factors that you look at when you're making your decisions on what the appropriate prescribing, which medication to prescribe, right? And as with any medication, you have informed decision making, and that involves engagement of the parents and the youth, right? Depending on the age, but obviously the older, the more engaged, and that involves discussions about risks and benefits, not only of the medications, but everything else involved, right? So this you've known. The old adage, especially with kids, start low and go slow. You want to seek the MED, the minimum effective dose for each medication, and that's again very evidence-based. You don't want to undertreat. Oh, we're providing blank antidepressant at this dose and underdosing. On the other hand, you certainly don't want to overtreat or withhold treatment, right? and that the dosing obviously is going to be based on a variety of different parameters, and not all our meds are based on weight or milligrams per kilo per day, and so therefore the rough, it'll come after this. The rough guide is you initiate with monotherapy. That it should be a rare exception to begin with 2 meds, right? And I know there'll be exceptions, right? But in general, 1 at a time, which is kind of a general rule, right? You either want to continue or initiate the psychosocial interventions, the non-pharmacologic interventions during the medication treatments as well. And that obviously part of that assessment, your initial treatment plan and your ongoing treatment plan, your initial treatment plan, and it gets updated, right, is how are we going to monitor and how are we going to manage for these potential adverse or side effects of the medication. And that should be part of the plan. And that's why we spend time on some of these tables as to which labs or not, because that's part of your treatment plan. And it's, well, people call it monitoring. A more active way of viewing is managing it, because it's not only monitoring, but you're managing because you're making decisions as you go along the way as a consequence of your monitoring. So in general, what do? We initiate a dose. We titrate upwards until our target symptoms improve. That means as a consequence of your initial assessment or your ongoing assessment, you've identified what those target symptoms are that you believe that medication's going to help with. Oh, my child has ADHD and they're getting bad grades in school and their grades are better now. Okay, well, the pills don't give you better grades, and that's kind of a more distal metric of, maybe of performance, but you don't necessarily want to look at something that's a second or a third, but you want to know what you're identifying that could be improved with the initiation of the medication. And obviously you want the family. Oh, we started this medication for that. And you go, really? And so is that medication for that? Is that, my child isn't cooperating, so they started blank antidepressant. Okay, so that medication is to help the child be more cooperative with you. And then you have, so you titrate up until you get improvement of those target symptoms, or you have rate-limiting intolerable side effects that have you say, gee, we're not at an optimal dose, but you're having these intolerable side effects, so we need to either decrease it, discontinue, transition over to another medication. In general, right? So those are just different overviews of some of the principles of practice that we know and some that relate to kids. And we know that especially because it's gotten better over the years, where people would really initiate 2 to 3 medications, and not just in acute care settings, right, and all in ambulatory settings. And then you can get into a whole bunch of problems, including these prescribing cascades where develop side effects, and then you think the side effects may be new symptoms or lack of response, and then you make decisions based on that, because if you begin 2 or 3 medications at one time, it's really unclear what some of those potential adverse effects could be, or which medication or which combinations generate that, and then you keep making changes based on this inappropriate assessment of what it is, and then it leads you up the path. And the other one, as we've spoken about, and as you all know, for example, is the appropriateness of the diagnosis, and hence in this last iteration of our DSM, or DSM-5, there was the generation of DMDD, disruptive mood dysregulation disorder, and a big impetus of that was the driver was a lot of the profound increase in the amount of children being diagnosed with bipolar disorder, juvenile bipolar disorder. And when the data was looked at longitudinally, I forget what percentage, but by far the great majority of those did not, over time into adulthood, really present with bipolar disorder. They had other issues, but it wasn't bipolar disorder, and as a consequence of that broad, using that broad phenotype, and not really DSM related, but that broad phenotype to diagnose bipolar disorder, they were started on all these medications and developed all these side effects and all of the things that we're talking about here today, and these morbidities, et cetera, and that people kept changing and making more changes, and kids were gaining weight and developing all these other issues, and that over time, when you back it up at the front end, is that maybe because they didn't have bipolar disorder, maybe the treatment should have been different. That's not to say we understand what DMDD is, right? That's a whole nother issue, but there was at least a driver of the fact that we really want to look at things at the front end, because by far we spend the most amount of time with the kids at the initial evaluation, and unless you're going to do some kind of comprehensive reevaluation along the way, every other visit really is much more finite and very, very limited in time and even maybe data. So it's really important to do that comprehensive assessment, because from there everything flows. So out of the two groups, as you heard, we're going to talk about antipsychotic medications. It's going to be a little bit more than stimulant medication. We'll talk about more broadly ADHD medications as well. But the big one, as we've talked about a little bit in some of these tables, will be antipsychotic medications. Let's talk about some safety issues and concerns. And you can see this is a big list of the more, not necessarily the most common, obviously, but the potential adverse effects that have the highest risk of morbidity, in some cases even mortality. But you'll see in a second how these are bigger concerns for adults than children, but that it should be something we should be at least aware of and monitoring as well. Even though weight changes, diabetes, and hyperlipidemia is at number one, we're going to skip that because we're going to spend a little bit more time as we go through this in that very specific area, and then move on from there, right? So let's talk about cardiovascular changes, right? So we know that you can have prolongation of QTc with certain of the antipsychotic medications, and other issues, whether that's orthostatic hypotension or even tachycardia, and I guess even other issues in adults. But that in kids, there's much more limited data on that. And that although we know that you can see QTc changes, certainly the abundance of the literature is in adults. So it's so finite that it's hard to make any specific recommendations on cardiovascular monitoring. And so for the record, there have been no case reports. I could not find any case reports of sudden cardiac death associated with use of atypicals in kids. Again, in my search, I couldn't find that. So it's less of an issue. The main issue is that you use your judgment, but from a practice monitoring, you're probably not going to generate some kind of baseline workup for anything cardiovascular unless there's something in a focus history or in your exam that would justify that. So moving on to agranulocytosis and neutropenia. Now we know the main antipsychotic that we discuss in this context is clozapine, right? That has these rare, potentially fatal cases of agranulocytosis. And although it's not clear, there's some suggestion in the literature that kids may be a little more at risk at that, but it's not that clear, right? And that there's a few it really hasn't translated into a lot of case report in kids, right? So then as you go through, it's really a way of summarizing. The way I put it by mind is that aside from clozapine, that relationship remains unclear in youth. That it means it may or may not, it may be other factors, but it really remains unclear. It's not as robust as some of the other things that we know. So again, there have been case reports of hepatic dysfunction issues in kids as well, and the causes, it's really, aside from the medications, it's not clear whether it's the rapid weight gain or issues with liver issues, whether it's fatty liver developing as a consequence or not, but that there have been case reports, right? And you know, and obviously there's been more issues with adults too, and that could be a variety of other factors, including the longitudinal nature of the meds being used or not. But that one has to look out for hepatic injury, especially with long-term use of these medications. Prolactin, right? So that's when this is even more controversial because we know that there are these elevations of prolactin levels with the use of these medications, of which the clinical, most of the times there's not a clinical correlation, right? And there's a big discrepancy between some of the guidelines that are generated out of Canada and out of UK, the NICE guidelines as the monitoring of prolactin levels. Because we know that different medications have a different propensity to increase prolactin, right? We know that large majority of kids with these medications have benign or don't show clinical manifestations of the prolactin level increase. Where the disagreement comes in is whether there should be routine monitoring of prolactin at baseline and at follow-up or not. Here, in our last consensus document, in general, we don't unless there's a clinical indication, because it's, according to the literature, it's not clear what that elevated prolactin is going to mean as far as risk without the concurrent physical symptoms, whether it's amenorrhea or gynecomastia, et cetera. And if you look at the Canadian guidelines and the UK's guidelines, they recommend monitoring it because the kids tend to have be at higher risk, and that the elevated levels are more likely to be predictive of something going to happen, but it's not clear. It's not as clear as what we have. So at some point when we get to that, I kept it as consistent with our other guidelines of not monitoring it routinely, but when we get to that in a second, you all can weigh in on how you think you want to manage that. You want to add anything on that, Dr. Stock? No? But it is a point of discussion because you can see there's different thresholds for it depending on where you live, right? Again, seizures, very rare, and so we know that these even benign EEG abnormalities can be reported with the use of antipsychotics, and that although seizures are probably mostly related with clozapine, there's really a lack of good systematic data in general in kids and antipsychotics, and these either the clinical significance or the frequency or the risks of these changes, with the exception of maybe clozapine, right? Like we talked about, EPS, is that off the screen? EPS, tardive dyskinesia, and others. We know can be an issue with all of these, right? And as a general review, we kind of think kids are more at risk of this, the movement issues, than adults, but it was, you'll see in a second, we translate that into the monitoring by assessing, just like similar to adults in the sense of assessing with vis-a-vis structured instruments, both at baseline and throughout treatment, to kind of monitor and make some decisions based on that, depending what we find, right? So in certain ways, even though, for example, TD, it's certainly not as common in kids, but we need to monitor for these other movements, right? So an MS we know is a potentially fatal but rare complication. And we know that I guess there are case reports with almost all the antipsychotics. I didn't review each single one, but I think there's case reports with all of them. And this is a severe but a very rare complication, right? So aside from educating, we just put it out on the table, make individuals aware, but not necessarily do any different or unique monitoring targeted towards that as well. And then let's move to the eyes. I want you to see this, right? You get it, right? And so we know you could have different kinds of ophthalmologic side effects. So in doing my review, I looked at it, and so there is non-human research looking at quetiapine with the development of cataracts in beagle. Beagle puppies. See now, and therefore, I guess whoever makes Seroquel, the quetiapine, inserted that in their product labeling, that it not only need to have an eye examination, but it should be examined specifically with like a slit lamp and real specific examination at the initiation of treatment and every 6 months thereafter during chronic therapy, because you want to look at detecting cataracts, right? And therefore see what you do. I could not find either any case reports of cataracts in youth who are being treated with any antipsychotic or any other published data suggesting that as well. And so therefore suggesting that although it may be an important issue in adults, and specifically to quetiapine, that we may want to stay silent regarding that in the sense of not recommending any specific monitoring guidelines for that as we move. But by far the biggest issue has to do with weight gain and metabolic syndrome, right? And that we know that led in 2004, I think, 3-4, where the American Diabetes Association and the APA, American Psychiatric Association, developed their consensus statement and guidelines on the monitoring of individuals in general who are being prescribed, antipsychotic medications. And as I've looked over through the different literature, I found that range of about 18 to about upper 30% of adherence with these monitoring. And again, the studies had all these different methodologies, and it was difficult, but just roughly to illustrate in general that the adherence with the monitoring is relatively low. And hopefully at the end we'll talk about a few issues that may enhance ability to kind of stick with or provide quality care with appropriate monitoring. And so we come up with guidelines, individuals come up with guidelines, and you can see the application is the execution of the guidelines is a little bit more of a challenge over time, right? So, and I'm going to go over a few slides, and at the end I'm going to show the table, and then we can talk about how to maybe change the table or not, and which areas we would like to either remove or edit, right? All the typical things we know about talking about proper nutrition and exercise, etc. Over the years, throughout some of our different meetings, we've had different experts address the issues of sometimes getting into these informed discussions with parents about having this understanding a priori that, look, we're going to initiate this medication, but if your child gains X amount of weight or this happens, we need to look at changing or stopping or making some decisions. Why? Because there's a lot of, at least anecdotal experience, where these things happen and the kids get better. And especially when we talked about the neurodevelopmental population, and they go, but wait, they're not being aggressive, but they've gained 40 pounds, and then you have a real issue on your hands because some of those target behaviors may have improved, but then the parent, God bless them, for a variety of different reasons. I always say, remember, you got to take that child home, right? We can talk about it here, but you're there at 11 o'clock at night when these things are happening, has to deal with it. So there is some suggestion of having this informed discussion up front, that if these things happen, then there's nothing guaranteed, right? But you should agree to have really take a look at this, whether it's worth it or not in the long run. Same thing, monitor for the side effects, as you know. These are the scales that we had in the general principles of practice for the schizophrenia section, and I believe they're all in the public domain, right? The discus is in the public domain? Yes? Okay. And that, so we know that the guidelines for metabolic syndrome in younger kids is less clear, right? And we know that the famous waist circumference, right, central adiposity, and weight gain in central adiposity is a big risk predictor, right? But as you've heard, and this was one of the things I was going to recommend as well, that in the real world it's very difficult, maybe not difficult to do, but very impractical. I mean, if one of the goals of generating guidelines is the practicality of it and and you already heard how people, the percentage of individuals who follow them is very relatively lower, and I was advocating, or I was going to put out a suggestion to eliminate waist circumference as a proxy, as another metric of that, because you'll see you'll have the others, whether it's weight or BMS and other factors to monitor that would be just as adequate and probably more time and resource sensitive in whatever practices you're at as well, right? With teenagers, even though the cutoff's at 10, 11 and above, it's really, you start being able to define the parameters a little bit more. And these are the latest ones that I could find as well, right? So, and then again, this is all leading up to the chart, because it really, in my mind, works a lot better in having your table and your chart where someone can glance at it and know a baseline at month blank, blank, blank. You can get your follow-ups, but that obviously the caveat is that if you have an individual with any particular circumstances or anything, that these are just guidelines, and you can consider doing the monitoring more frequently if you think it's appropriate for that one individual. And then this was the prolactin discussion, right, where we talked about in the past, the consensus has been here in the US that routine monitoring of prolactin is not indicated, not justified unless there's some very specific reason, right? But that because we don't know what increased levels of prolactin mean over the long term in general, that we don't monitor it unless there's physical symptoms or the beginning of physical symptoms of that, right? I think everybody agrees about using the structured instruments to assess for side effects, right? Like an AIMS, whatever you're going to use. Okay, so let's go on to ADHD meds. As you know, all the typical things. So one is obviously sleep. And it's usually the insomnias and not the parasomnias. And the two biggest issues are either the increase in the sleep onset, which is sleep latency, the time from when you get in bed or when you should be in bed and fall asleep. And the other is the total decreased sleep time, which is, hey, sleeping X hours versus that, right? So monitoring what that already is, especially if they're teenagers at pre-treatment baseline, and then monitoring throughout treatment, right? Cardiovascular side effects, this has been looked at quite a bit over the years, and we know that there's typically, with stimulants now, this is just the stimulants, there's a benign increase in the heart rate, the pulse, and the blood pressure, and it's usually clinically insignificant. In 2008, the American Heart Association came out with this whole guideline related to SCDs, sudden cardiac death, and other issues. And subsequent to that, we've learned a lot more, and that has changed in our perspective of what we do as screening and follow-ups, because not only do we know it's rare, but as you'll see, it's based at looking at the general population with the use of stimulants. It tends not to be higher than the general populations in the absence of pre-existing cardiovascular disease, right? So in general, it appears that in the absence of that cardiovascular disease, that kids who receive stimulants are not at greater risk for these catastrophic events like sudden cardiac death with the use of stimulants, right? Heightened growth, well, we know they can be associated with that. Again, there's all this variety of different literature because of the methodologies and the continuity of the meds and medication breaks, and look at that. But that in general, we think that there may be some minor growth decrease in kids with chronic or long-term use of stimulants, and that it may be related to dose and or duration of treatment. There does not appear to be a difference between whether it's an amphetamine-based product or a methylphenidate-based product or an immediate release versus extended or long-term, and that it's not really clear, but we really think that maybe these medication holidays may help contribute to help that be less of an issue, right? Quickly about the non-stimulants, right? Because again, we're used the non-stimulant medications, which either include the alpha-2 agonists, guanfacine-based products or clonidine-based products, or atomoxetine, sold commercially as Strattera, each have their own, some of their side effects, right? So we know that, for example, the guanfacine and clonidine can be associated with decreased blood pressure, as you can imagine. That's how they were originally developed. And atomoxetine maybe at times can increase and have the effect the other way. But in either case, those tend to be relatively low frequency side effects. We know specifically with higher doses, especially of guanfacine and clonidine, abrupt discontinuation at times can lead to rebound hypertension. So one has to be careful how a child is tapered off, right? We know that there's been these, and I'm not sure even how many case reports there are of these cardiovascular related deaths with atomoxetines, and that it looks like if there was pre-existing cardiovascular disease which is again similar, that diathesis, that predisposition is the similar risk as with the stimulants. Atomoxetine comes with its warning about liver enzymes, and it's typically benign typically liver enzymes. That means when you discontinue the medication, it tends to, all your parameters tend to return to normal, right? And that also atomoxetine has been associated with some growth issues. You do need to know that as well, that it's not the stimulants. It's not just saying, hey, all non-stimulants don't have any growth-related issues as well, and that you do need to monitor that as well. So, atomoxetine has, because it's structurally very similar, it has a box warning, formerly known as a black box warning, and that's a class kind of specific warning. And side effects, clinically, I don't see that, but that should be part of the monitoring, and that should be part of the informed decision making and the education of the families, et cetera, et cetera. So one needs to know that as well. Gosh, that says antipsychotics, and this says antipsychotics, and I think when I was cutting and pasting last night, it should say ADHD, but it's ADHD, tell by the brain, right? So obviously, you get your general history, right, but you get your family health history, as you mentioned earlier, not only for the individual, but with a particular focus on cardiovascular disease, right? Both the child, the youth, and at least first-degree biological relatives, right? That's a class 1 recommendation, so the American Heart Association used class instead of levels, right? Including history of any specific cardiac symptoms. And I even went very granular here, but it's not that granular, right? The big one is sudden cardiac death, right? But basically, you're looking for history of any electrophysiologic problems, right? Conduction problems, arrhythmias, things like that, right? Or structural, right? It could be structural because the data is mixed. It's not just all electrophysiologic. It could be structural as well. And then, if any of that history is positive, then you consider additional evaluation. And so obtaining an EKG before treatment is considered a 2A, to level 2 decision, because when those first recommendations came out in 2008, everybody gets an EKG before you start a priori, and you can't start any treatment. And what we found since, when you look at it, remember, an EKG is very cross-sectional, right, in the moment. And when you look at what we've learned as far as the risks with it and the frequency, if the history and or the physical examination is suggestive of some cardiac disease, then yes, you do want to get an EKG at the very least, and or further evaluation before initiating treatment, right? But if not, then the evidence doesn't support getting blanket routine EKGs on every child before you begin a, let's say, a stimulant, right? When you, again, look at all these issues, then the question is, gosh, we're going to start, take your pick, X stimulant, and we need to get all these labs at baseline versus an annual physical exam. So we'll talk about that in a second when we get to the table, right? But the main impetus of this is because we still hear a lot about EKGs. Everybody's got to get an EKG, everybody's got to get an EKG, everybody's got to get an EKG. And you want to be a little bit more selective or focused on that decision, right? When I went and looked at all the cardiovascular literature as well about the use of atomoxetine, so it means, it depends on how serious it is, but you do want to get that, consider if you do find pre-existing or you have some cardiac symptoms, whether it's vis-a-vis history or in physical exam, you do want to get that to get further looked at if you're considering using atomoxetine, right? And then you decide, even though those case reports are very rare, right? But it's that evidence of pre-existing disease, right? As we said, you want to measure, you want to monitor the sleep changes. You will see that ever so frequently. And as we've said over and over again, this is like the second or third hit on this, is to stay away from using antipsychotic medications for sleep issues. Briefly touching on tics is that you need to know there is a relationship between the potential relationship between the use of tics or not, even though there's some literature that if kids treated with tics get better, but that you want to be careful and you want to assess to try to determine that connection if a child develops tics, whether it may be medication related or not, and make your decisions, right, about utilizing it. And that it's a relative contraindication, that is, it's not an absolute contraindication. If the child develops tics, that you absolutely stop it. It's that you make your decisions and your judgments on that as well, right? We're going to get to this in a second about on the table of what to do with the getting the height, the weight, right? And then I put plot because most people, a lot of practices, it'll be plotting it on the chart, right? And then you kind of see where the kids are going with their height and weight. And then again, that's not completely evidence. It's a lower level evidence base about catch-up growth and all that, but I just inserted that in there. So lastly, we started what the barriers were, but some of the things that may be potential facilitators when you either look at speaking with different practices or look at the literature. Obviously, we start with awareness of the guidelines, hence all the wonderful work here that you all are doing and Marie and the team's doing, is that here's these guidelines, you got to be aware of it before you can know what to monitor, right? And then secondly, we know that providers' agreement with the guidelines. So this is why we're spending a lot of time discussing, because we found that adherence, following up, complying is more likely with the more you agree with what's contained in a guideline, right? Self-efficacy, you know how much you can feel you can do that, right? Overcoming, well, this is the opposite of inertia, right? So it's like, well, I've always done it like this, I don't need to. So it's when it gets reframed the other way around, it's instead of practice inertia, it's overcoming your previous practice patterns, if that's what it was, right, as you're kind of rolling out. And as we talked at the very beginning, if you want to move it back more, remove more distal, it's like learning that way back here as a medical student or as a resident, so therefore you don't have to overcome that inertia when you're in practice, and then you can hopefully get that. And then your outcome expectancy. So yeah, but if I do this, what's the difference, right? Is that going to change anything I'm going to do? And yes, the answer is yes. But there's a whole set of individuals, when you look at the literature, that don't see that things would be different if they were to monitor these things, right? And so, on that note, right, we appreciate it. Any other final questions or comments, please?